Visit WPS today to start unlocking potential.
At WPS, when we develop a new test, we bring an author's idea to life. We answer a researcher's question, meet a clinician's need, and ideally change an individual's life for the better. We are unlocking potential. So on the next slide, you'll see the bio for Dr. Ann Rogers. She is a PhD in school psychology with specializations in neuropsychology and developmental psychology. She is a nationally certified school psychologist and has worked in the field of assessment for over 25 years in various roles with test publishers, as a practitioner in schools and in private agencies, in neuroscience, pharma medical education program development, and as an adjunct university instructor for school psychology training programs. Dr. Rogers is currently a business development manager with Western Psychological Services, the premier provider of resources for assessing autism spectrum disorder. I am very happy and lucky to call her my colleague, and I'd like to give an esteemed welcome to Dr. Ann Rogers. Welcome.
Thank you, Stephanie, and welcome everyone. I am not seeing the chat as my colleague Stephanie is, but I understand that we have folks from a lot of different places today, and I'm very pleased that you could join us. So with this bio, I was a little bit brief. Don't you hate when you go to a talk and the speaker's bio is about as long as the first 10 slides of the talk? So I try not to do that to people, but I do want to mention, because it's pertinent to today, that I do have a background with autism specifically. So I have a family member on the spectrum, and I will be mentioning him from time to time. This bio kind of begins with grad school. Prior to that, as many of you on this call probably did, I had a lot of firsthand direct experience in various programs, whether they be sheltered workshops or residential settings with children and adults on the spectrum. I also want to mention that a lot of the references, most every slide has a reference, but I tended to seek out things that were open access or able to be downloaded without a cost, so that if you choose later to use the links and investigate further in the article that I've quoted, you're able to do so without having to pay for the article. So having said that, there's only a limited amount of time and a limited amount of slides that I can give you. So there's always a point counterpoint, right? When I teach courses at the university level, undergrad and graduate school, what I like to do is, obviously, you have to choose a textbook. You choose some research articles that you want the students to read. But I used to always also prepare an alternative reading list that was the opposite point of view, because I think that's important for people to do. You don't want to just get a one-sided view. Now, I haven't done that today, so you're going to have to do that on your own. But it's something that I think is important. So if you disagree with a statement that's made on a slide, I encourage you to click on the link, read the article for yourself, and then form your opinion afterwards. So, but as we move forward, I think those are some of certain things that I wanted to cover and get some background that I wanted to make sure you were aware of. So before we jump into the actual presentation in terms of the objectives that you all read when you registered, I want to show you a couple things. We're going to talk just about a snapshot, a couple slides about mental health in general. I don't like to be read to during a presentation, so I won't read these to you. And remember that you will also get the slides later after the talk. But I think it's really important for us to think about mental health in general, and the fact that suicide claims the lives of more than 700,000 people worldwide each year, the suicide rate in kids and adults is increasing. And it is the second leading cause of death in children and young adults. And I think if you're up on the news, and I'm sure most of you are, and I apologize to those who are joining from another country, because I'm about to quote the US Surgeon General, but the Surgeon General for the US recently put out an advisory that even before the pandemic, there were serious issues with depression, anxiety, and problems with suicide in our young adults. Now, as we all know, we're struggling right now with issues of assessment, issues of diagnosis and treatment with COVID. It's even worse. So I just wanted to bring this up and have you think about, it's kind of a bad way to start your day, isn't it? It's a little bit depressing, but it's also something to keep top of mind, because as we move in to discussing autism, the next slide will show you that kids on the spectrum are twice as likely to report suicidal thoughts. And according to the second research article, most of the time, children with autism are not screened for suicide risk. And you want to ask me, how low do we go? I don't know that I have a definitive answer for that. But when you look at the national statistics and you look at the Surgeon General's report, which is one of the links on the previous slide, you'll see that it is children, adolescents, as well as adults. So it's something to consider, how you go about screening, how you go about having those conversations. I can't direct you, but I do want to point out that these articles occurred prior to COVID, and these stats were prior to COVID. Now think about how much more difficult things are. And that leads me to really talking about the webinar objectives today. So when you saw the description of today's talk, you saw that what I really want to do, and in the first bullet, is really look at mental health challenges for autistic individuals. And that is across the lifespan. So we'll talk about some things in childhood, some things in adolescence, and quite a bit in adulthood, since that was the bolus of many of the questions that came in. And, excuse me, the second bullet, integrating various assessment methods. So this talk was not designed to teach you how to diagnose autism per se. We have a lot of questions about assessment, so we'll touch on those probably in the Q&A more heavily than during the talk. This talk was to take the aspect of mental health and really make that the presenting issue. And then, as something that I hope is helpful in clinical practice, is to include some interventions. So there are some examples of interventions for each of those ages as well. So keep in mind, the majority of today's talk is about, yes, it has diagnostic in it, but we're looking at what happens to the autistic person throughout their lifespan and some of those issues, the consequences of having that label. So because there were so many questions on diagnosis, I just added this slide. The National Autism Center is one resource. There are others, but 6 components. Usually, if you have all 6 of these, you have a comprehensive diagnostic evaluation. So of course, and I'm sure all of you do this anyway, a review of relevant medical, psychological, or school records. When I was in grad school, one of my professors on my committee always said, the answer's in the history. The answer's in the history, Rogers. And so obviously this first bullet is very important, and I agree. The parent or the caregiver interview. cognitive and developmental assessments, direct play observation. That's not something that is automatically done. Some of that is contained within some assessment tools, for example, ADOS. But I think it's important to pull that piece out because you get a lot of information from a direct play observation, not just an observation of how the person does in math class or science or reading. Adaptive functioning is obviously quite important, and a comprehensive medical examination. We will talk a bit about comorbidity today in terms of mental health. I did not include a lot of information on other comorbid conditions. For example, gastrointestinal issues are very highly seen in autistic individuals, but I have not included that in today's talk. So this is a snapshot, again, another snapshot, but of evaluation components. What I don't see here is an interview with the student or the child or the adult. I think it's assumed, but it's not listed. So I think we will spend some time talking about that today as well. What you also don't see is a measure of some of the other comorbid conditions, the mental health issues, anxiety, depression, self-concept, and those are things that we will include today. So before we launch into that, let's just have a quick update on prevalence, because for some of you, this may surprise you, others maybe not. It depends on how deeply you have watched the news and some of these research articles. So in 2018, the Autism and Developmental Disabilities Monitoring Network, their surveillance summary, it was just published in December. Another reason why I gave a shout out to my colleagues in creating these slides, because this was a late breaking document. So now look at this first bullet. Now we're up to 1 in 44 children. I remember when I first was being trained, autism was something that I was told was 1 in 10,000 births. And now we're up to 1 in 44. During this surveillance and of these sites that are surveyed, the overall male to female prevalence ratio was 4 to 2. And as you can see in the last bullet, from 2000 to now, we've gone from 1 in 150 to 1 in 54, and now the latest publication, 1 in 44. The percentage of American school children receiving special education services as a result of an autism diagnosis has doubled in 10 years. And this data came from 2008 to 2018 data recording. So double for special education referrals. And as you can see in the second bullet, ages 6 to 21, 10% were identified as having autism. And this comes from the Fast Facts that OSERS puts out. They have not updated this document for a while, so this is the latest that they have published. But Rubenstein also took a look at data, and he compared trends in 12 categories of special education. And again, this is in the US. And he used the same monitoring data that I cited a moment ago for the 1 in 44. And he looked at the surveillance years, 2002, 6, 8, and 10. And I encourage you, if you've never looked at these reports, to use the live link on the data monitoring, as well as this article, and take a look at the sites that are included, how the data is collected, and have your own opinion on that research. Of 6,000 children with autism, more than 36% did not receive an autism eligibility in each of those surveillance years. And I think that's interesting because we just had the other that said 1 in 44, and we had the doubling of the data that the US government put out in terms of special education. And now we have this data. So again, decide for yourself, look, but there are probably a lot of reasons. And when you think about the reasons for eligibility in schools, that educational need is probably the pivotal point. And this talk today is not designed to pick apart IDEA or the federal law in the US in terms of autism eligibility. We are going to spend more time with the diagnostic and statistical manual, but I just thought you might find this interesting. A brief slide talking about bilingual, because that is something that comes up quite a bit. And these are two articles that said they compared the social abilities and language levels of children with autism from bilingual and from monolingual environments. And the second research was specifically Spanish English. They did not, the bilingually exposed children did not experience any additional delays in their language development. And the second article again says it did not negatively affect language development in the young children. And so this is food for thought and could be a whole nother discussion that we have in terms of bilingual and monolingual environments and language development. All of that speaks again to criteria for the disorder and for the condition, the disorder, whatever term that is used in the research. But I thought you might find that of interest. It's not intuitively what we would say because there's a lot of early research on reading and language development that would make you question this and say, well, it is confusing. There are issues. So probably you need to pick a primary language spoken in the home. My nephew, I said I would bring up family. I have a nephew that was adopted from Guatemala. We knew when he was born, the family, because my niece, his older sister, is also adopted from Guatemala. But in between the referral and when we traveled to country to get Michael, a lot happened in the world and there was quite a delay. So whereas my niece came home at 6 months, my nephew, we didn't go to pick him up until he was 18 months old. And at the time in that country and where he was living, there were no orphanages, there were no formal environments for children had been given up for adoption. Every single child goes to a foster family, and very tight-knit, very wonderful families. In fact, my brother and his wife are still in touch with those families. But the point being, he had spent 18 months with some people that he thought were his family and spoke only Spanish and was only exposed to Spanish. When he first came home, even with all of the experiences that I've told you about thus far, I really thought that language issues were the problem because it was evident in the beginning. He was very quiet, very reserved, a little bit slow to respond at times, kind of fearful. So I thought it's because that he had only heard Spanish for 18 months and now was being thrown into this really crazy US family, talks a lot in English. And so ultimately he wasn't diagnosed until he was in junior high, but just speaking to experience, it's sometimes difficult. And if you're out there and you're working with families and you have similar kinds of things that you're trying to determine, it's difficult sometimes if it's language or culture or autism. Don't have an exact answer, but wanted to raise the point with you today. And back to just a prevalence statistic, we talk about adults. The CDC, the Centers for Disease Control and Prevention, the last time they published adult data was in 2017. And at that time, their estimated prevalence, as you can see on the slide, was about 2.21% of the population. I can't tell you whether they were diagnosed late in life, if they've been tracked. A lot of this data was based on population data, and some of it was tracking of previously identified folks over time. But that's still a large portion of the population that really needs attention, and hopefully we'll talk about a little bit in more detail today, is the adults. And I could tell from the questions that came in that adult services, adult diagnoses, et cetera, are on your minds as well. Why are we not sure about adults? Well, they might remain unrecognized. And I encourage you to read this article when you have time. It's pretty extensive. This is just some bullets that I pulled from it. But it talks about missed diagnoses as well as missed diagnoses, missed and miss. And so maybe they've never been referred, or maybe they've been incorrectly diagnosed over the course of their life. And back to my my experiences in residential, we had the one home, the deinstitutionalization home with the autistic children. Then there was a second home that they opened, and this was quite a group of kiddos with a lot of different diagnoses that they came to us with, and probably should not have all been mixed together, but I know that schizophrenia is often a differential, and that came through in the questions as well. So sometimes it's just a miss on the diagnosis. And so today, that's one of the reasons why I really wanted to revisit the Diagnostic and Statistical Manual, DSM, because we really want to be careful about this. We also might be talking about comorbidity. And so when we think about mental health issues in autism, we really need to think about comorbidity, and we will be discussing that quite heavily. So let's look at the DSM. Had to give you this slide, late breaking slide. I don't know if you saw it, but it came through the news just on St. Patrick's Day that the text revision is now available. And there were 2 changes to what they said about autism in the DSM-5 TR. So the first one is the criteria. So whereas earlier versions of DSM would say just difficulties in social, difficulties in this, difficulties in that, but it didn't, the majority of practitioners who wrote into the working groups would say, do they have to have 1 or 2? Like if you remember, the DSM-4 TR said 2 of these, 3 of these, etc. So folks were still in that mindset and really challenged the DSM working groups. What do we do? And so now it very clearly will say, and in the next versions will say, as manifested by all of the following, and that's under criterion A. The second change was within the specifiers. So if you have used DSM to diagnose, and let me add something, since the majority of our poll members were from school environments, If you're a school psychologist, you're still a psychologist. So even though your marching orders and your operational orders are IDEA, you still should know DSM. And so what was difficult about DSM was when you had to say whether a person's autism was associated with another, and you can read neurodevelopmental, mental, or behavioral disorder. That very clearly spoke to comorbidity and folks, but at the time in DSM-5, there were coding that had to be done. And so what clinicians had to really do was come up with another code for a formal, quote, disorder. So ADHD as a comorbid condition, and the code for ADHD, etc. Now it's a loosening of the criteria under those specifiers, and now it can say the word problem. And so although codes are still encouraged, and we will all experience what insurance companies may do with this, the requirement for a diagnosable condition with a code has been removed. So I just want to throw that out there. It's brand new. It's only a couple weeks old. I'm sure there will be a lot of discussion and other webinars that you attend, or team meetings, or lunch and learns, whatever criteria or whatever method you use to keep current, it'll probably come up again. But for today's purposes, I'm sticking with some of the original wording. And so criterion A, persistent deficits in social communication and social interaction across multiple contexts. And if you use the DSM, you know that under each criterion, there are several examples. They're not exhaustive. They're meant to be illustrations. I chose this one because we're going to be talking about this kind of example today. So deficits in developing, maintaining and understanding relationships, ranging from difficulties just adjusting behavior to suit social context, to difficulties in sharing imaginative play, or in making friends, etc. And so let's pull this apart a little bit. Developing, maintaining, and understanding relationships. We'll be talking about those, and those do have consequences for mental health for persons who are autistic. Difficulties in adjusting behavior to suit various social contexts, very relevant, and we'll be talking about some ways to assess those. Difficulties in sharing imaginative play. So if any of you have done a play observation like we talked about earlier, or if you've given the ADOS, you know that imaginative play is something very important. So my purpose is to take the DSM today, double click on a few of these things, and we'll talk about how they're relevant to mental health. So one thing of interest under criterion A, and I've had some questions on it. While boys and girls are socially excluded more than peers, those autistic children are socially excluded more. Boys, excuse me, were more overtly excluded, and girls just seem to be overlooked. And so these two articles from Michelle Dean, I encourage you to look at. She does a lot of research. Her research involves peer nomination and a lot of gender differences, male, female, just in general in terms of development and social interaction. And then a layer on top of that of autism. And I think what's interesting about her research is she also makes the point that both boys who are autistic and girls who are autistic tended, as per typical peers, to prefer same-sex play. So the girls hung together, the guys hung together, but the girls were much more subtle, much more language-based, the necessary to get nominated. And remember, this research is based on peer nomination. There's a lot of subtleties and a lot of interaction demands with the females. The boys, it was more overt play, games and rule governed play, baseball and so forth on the playground. And so she makes the point that given the need for reciprocal friendship and association, the girls might have felt even more excluded than the boys. And so there's a big consequence there for mental health and depression. There are a lot of social and emotional risks with females. And she also suggests that because girls with autism may have stronger difficulty monitoring salient things and subtle things about relationships, such as interpreting nuance, how to be intimate, how to confront folks with similar interests, that when interventions are created, there might need to be gender differences considered. So interventions for boys socially in school and on the playground might look different than the skills that females need to acquire to feel more a part of a group and to be included more. So just something to consider. And again, these two articles go into quite a bit of depth on the consequences of particularly how females might feel compared to their peers. One way to assess this, and this is not, we'll talk about assessment in the Q&A at the end. I don't want to show a bunch of different assessment tools, but if you've not seen this one, it is relevant to criterion A, to social, to how to measure social responsiveness, how to measure social relationships, and take a second look at that criterion A in a way that is very research-based, and where if you need to get a score, you can. The social responsiveness scale, John Constantino. Let's take a look, just a brief look. The SRS-2 is available from preschool, 2.5, it's actually 30 months, up through adulthood. It is a rating scale. It identifies social impairment and it quantifies the level of severity. It's a rating scale that can be filled out by a parent, a teacher. There's a self-report version in the adult range, or an other. So if you have a job coach or some other kind of relevant person in this person's life that can be a good rater, you can include them as well. It's available in paper or on the WPS online system. And it's consistent with DSM. So they have a total score and it has DSM compatible scale. So it is the dyad of social and restricted interests and repetitive behaviors. What's very interesting about the SRS and what useful about the SRS are the treatment scales. So if you look at this slide, if you're not familiar with the test, you will be able to go later to the WPS website and take a closer look. This is not meant to be a full-on training about SRS. It's just an introduction for one tool that can help you look at criterion A. Social awareness, cognition, communication, social motivation. So over time, you can look at the scores on these, and then you can also monitor changes in these as treatment scales, depending on your intervention that you might employ in your clinical practice. So wanted to show you that one. Another tool that's relevant for criterion A for social deficits is the CAPS. So this one is primarily, and if you're, I know we have some speech and language pathologists in the audience today. This is designed primarily to be done as a speech and language tool. But the CAPS, what's interesting about it and why I recommend it is because it's done in a video format. And so later in this talk, when we talk about things such as camouflaging, masking, etc., a way to address this in your assessment could be to use the CAPS. It has video scenarios where the client watches a video and then they're asked some questions. And so we're looking at their interpretation of a social scene and then how they would do it differently. So the questions typically go, was there something wrong in this video? What was wrong? What can they do differently? And so why this is different, they're real life. So it has a lot of validity in terms of environment, and it gets the student or the student away from scripted language, which I think is something that we all run up against, is they have the right answer because they've been in social skills groups over and over and over. So this forces a more realistic look at social interaction. So they might look at things like basic social routines, taking turns, awareness of context clues, and the ability to understand the intent of what others or infer what they're thinking. They might need to detect a speaker's intent by looking at nonverbal cues that are present in the video, voice inflection, prosody, etc. Looking at routine language and their ability to express higher order pragmatic skills. So all of this speaks to what we've talked about in criterion A, and also what we mentioned just a moment ago about some of the difficulties male, female in interpreting social situations and what that might look like, and the research that was done in terms of school age and playground behavior. And this is just another slide discussing the CAPS, ages 7 to 18. So this one goes up to 18. This is not one that we do with adults as this SRS, but it is available through a good range of ages. And this is just a little screenshot showing you what some of the videos look like. They're very realistic. You play them, and it's also available as when I showed you the first slide, there is a jump drive with the videos that you can administer that way, or it is available as well on the WPS online system. So think about the CAPS as a way to really double click on that social awareness, as well as the SRS2, breaking down social, not just looking at are they socially engaged or not, but further that next level of social motivation, social cognition, etc. And with the CAPS, this awareness of routines and the ability to describe them, to infer intent, all of those things that are difficult for people on the spectrum. So moving on to DSM again, criterion C is that the symptoms be present in the early developmental period, but may not become fully manifested until later in life. And this is where we're going to talk a bit more about adults and masking. So autistic masking is an emerging research area. Conscious or unconscious suppression of autistic responses and adopting alternatives across. So again, I had a brief conversation with the author of the CAPS one day, and I had talked about masking because this is an issue both in adolescents and adults. And I feel like probably if the CAPS, once you get your own internal norms to go along with how the test is scored, you might be able to take a nice look at masking through using that tool. It may relate to negative outcomes, mental health issues, burnout, and suicidality. It's often proposed as one explanation for gender disparities in that 4:2 male to female ratio. Not everyone agrees with that masking is one contributor, but some do. And it definitely contributes to a late in life diagnosis for a lot of adults. So the Thompson Center for Autism and Neurodevelopmental Disorders, it had a webinar. This is, they're located in Missouri. They sponsored a webinar. The person who did the webinar, her name is Haley Moss. She has a website that's listed as the reference down below. And the whole webinar was about masking. And she mentioned that especially women, people of color and gender go undiagnosed as a price of masking. Mental and physical exhaustion, depression and anxiety, loss of identity. And so we will put it up at the end. And my colleague, Stephanie, maybe she'll remind me to do so. I have a flyer too. She's going to be speaking again on April 12th. The topic is not centered only on masking, but she's a great speaker. She is a person with autism, and she speaks on a number of topics from a personal perspective. So I encourage you, if you have time, it's a free webinar sponsored by the Thompson Center. But let's look at masking in a little more detail, because we're looking at mental health consequences. So there's something called the Autistic Traits Questionnaire. It's not published by WPS. I'm not that familiar with the tool, but the point was these folks filled out this test, and that greater self-reported camouflaging was associated with very poor mental health outcomes. And so camouflaging and masking are two terms. Some of the literature uses them interchangeably. Some says that camouflaging is an overall umbrella, masking is as a component. I'm sure when you do your reading, you will decide. But in this study, there was no moderating effect of gender. So see, remember when I told you I present the yin and the yang? This is a study who said, nope, there was really no moderating effect of gender when they looked at the camouflaging, self-reported camouflaging. But there was a very significant look at poor mental health, and it appeared to be linear, meaning the greater the camouflaging, the more mental health issues that were seen in this study. So another term is autistic fatigue and autistic burnout. They are terms that come from autistic people. And according to the National Autistic Society, this is in the UK, they say we are learning from these experiences. It's a fairly new term. If you've not heard it before, it's fairly new, but there's a lot of current research being done. Fatigue and then burnout are very important to the concepts of masking. So we went from masking and camouflaging to a consequence. Consequence can be autistic fatigue and burnout. And folks report that pressures of everyday life, having to navigate constantly social situations and sensory overload make this a very plausible problem. And trying to cope can lead to exhaustion and burnout. So what does that look like? Various ways: fatigue, meltdown, sensory sensitivity, physical pain, etc. So this is a consequence of masking and something for us to consider. So moving along, we talked about, this is criterion A and C. So changes in routines can increase anxiety, dealing with various social situations. Sensory overload is very important to this process. And suppressing stimming is something that most autistic people consider to be a difficulty. Forcing to hide their autistic traits. So moving along, what burnout may look like in children, you can see on the slide. Decreases in vocabulary, emotional volatility, increased stimming, reduced eye contact. These are things that sometimes in the school systems and in clinical environments just get passed as difficulties with behavior. But to really look at why this may be happening is something for you to consider: autistic burnout and fatigue. Criterion B in DSM, restricted and repetitive patterns of behavior. So we're all familiar with this, but in DSM-5, the concept of hyper or hyporeactivity to sensory input was introduced. It wasn't there before. And so again, sensory input, how that affects mental health consequences downstream is something that we're going to look at. We just did when we looked at masking and burnout. And sensory difficulties can be recognized very early. So I want you to see the next clip is a video. Let's look at Dr. Lord and listen to this about sensory.
Many children who don't have autism have strong reactions to sensations. So they may not like loud noises, or they may not like the tags in their clothes, or they may not want to touch, taste. What separates children with autism is they may have more of these sensory difficulties, often coupled with repetitive behaviors. For example, looking out of the corner of their eyes, or hand and finger movements that go on for more than a second. I mean, typical babies sometimes look at their hands or flap their hands, but they don't go on doing this in the same rhythm over a longer period of time. They may want to turn on a noisy electronic toy, and then they may put their hands over their ears because the noise of the toy bothers them. And they may do this over and over. It's important to observe the sensory behaviors, especially of very young children, carefully, because many children with autism do actually have unusual reactions to the sensory environment. But it's easy to miss them or just discount them because we're not being careful enough. So being conscious of a child who picks up a block and places it in exactly the same place in peripheral vision, or a child who's smelling plastic toys before they hold them over their head, or a child who has a very particular hand movement. It is really important because it does give us a clue that something is unusual. On the other hand, these behaviors are a real mystery in trying to figure out why they happen. And so we don't know what they mean. We just know that they're an indicator of autism, and also something that we want to be conscious of in terms of planning a child's environment.
I thought you might all find that interesting. Dr. Lord is also an author on the ADOS. So looking at problems in sensory, 74% of the children had differences in how they responded to sensory stimuli. We've already talked about criterion A, we've talked about C, we've talked about masking and difficulty with sensory areas. Rousseau in 2021, externalizing mental health symptoms like hyperactivity were related to sensory seeking, and internalizing were related to depression. And so again, we find we need to maybe do a double click. When you're doing an evaluation, do they just not look up autistic? What are the areas specifically under these criteria that you can assess in more depth to plan better interventions? And we're not going to play other clips. We're looking at time, but I want to refer you, and it will be available in the chat. There are other videos available from different authors. WPS has a YouTube page, and you can click on a number of videos and look at what the authors and different experts have to say. This happens to be the sensory processing measure. I bring it up because it's a very good way to look at sensory processing and integration issues. It's also a lifespan tool from infant, toddler, clear up through adult, and it also has accompanying quick tips, which are publishing in various stages, but the quick tips are intervention pieces. sensory functioning, praxis, and social participation across the lifespan. And again, there's more information on any of these tools available on the WPS website or from your assessment consultant. But I wanted to bring this up because in a standard evaluation, this tool is able to be given by psychologists. I used to give it before I came to WPS as when I was looking at doing functional behavior assessments. Are they seeking sensory information? Are they avoiding sensory information? Are there particular vulnerabilities to be looked at? Because as we've seen over time in these slides, long-term consequences can be sensory overload. And how does that manifest as a mental health concern? The Montero guidelines is also a lifespan measure, and these are included because we had a lot of questions on diagnosis, but also because I'm referring back to social and sensory issues. The MIGDAS is a sensory-based approach to diagnosis and assessment of autism. And so briefly, there are various components. There are teacher questionnaires, parent questionnaires, but the bolus of the MIGDAS is the interaction with the person. And this is also, there are versions that go up through adulthood. And this is something that I encourage you to look at. It's a sensory-based approach. It has particular, you look at the person's perspective, their perspective. It's less on language and more on how the autistic brain, how you assess the autistic person. And it's gathering and organizing information. It's a behavioral profile that describes the individual's distinct way of looking at the world. And again, Dr. Montero, if you go to the WPS website, you can look at some of the prior trainings that she's done, and she also speaks in detail to the concept of masking. Because this is a direct assessment with the person and the ability for them to give their life story and come from their preferred interests and activities, there is less of a demand for masking and camouflaging with the MIGDAS than perhaps in some other tools. And there are also, as I said, on the YouTube page, Dr. Montero has various free webinars that you can look at. So again, additional conditions, again, just reminding that before there had to be, when you're talking about comorbidity, now it can be just an associated problem, and it doesn't have to be a coded disorder. What I wanted to bring up now in some of the remaining time is to talk more about comorbidity and then talk some about interventions before we go to the Q&A. The co-occurrence is about 83%, and the co-occurrence of one or more psychiatric diagnoses is about 10%. One study even estimated that autism and ADHD could be about 37 to 85% of the children with autism. This speaks quite a bit to interventions, doesn't it? A large proportion of the children in these research studies quoted had their first mental health symptoms prior to the age of 5. Some report rates as high as 95%. %78% of these children with autism had at least one mental health concern. Even the preschool age children. Among children with autism, anxiety, attention deficit disorder, oppositional defiant disorder, these are the predominant co-occurring conditions. But anxiety remains very high, and we've talked about anxiety with masking and transition to adulthood. Depression, anxiety sometimes looks differently, but depression increases in adulthood. For depression and anxiety are what we most often see with adults, whereas with children, it seems to be that ADHD is the predominant comorbid disorder. And a lot of these slides are statistics for you to look at later in terms of the fact that we really need to look at comorbid conditions, depression, anxiety. 31 studies that focused on the presence of anxiety. 40% of the children had at least one diagnosable condition of anxiety. One way to look at this when you're doing assessments is the RCMAS, the revised version, and that's available again in print or on the WPS system. It is a self-report. These are the age ranges down to 6 and up to 19. If you're able to be working with someone who can do self-report, I highly recommend that you consider these statistics we just talked about with anxiety and include a measure of anxiety in your assessment. And the Pierce-Harris is another self-concept scale of value, again, to include. These are things that I'm bringing up today because we shouldn't just try to see how did they score on the ADOS, how did they score on a GARS, but to include all of these other measures when we talk about a comprehensive evaluation, and to be cognizant of the mental health needs over time of children and adults on the spectrum. Self-report for the Pierce-Harris goes up to 22 years. And again, these are just suggestions. I'm not going to belabor a conversation about any of these tools because you can find out more on the WPS website or through your assessment consultant. So let's quickly look at some intervention examples and resources. So we come through criterion A, social, and we've looked at the sensory issues. We've looked at masking and camouflaging. We've looked at some gender issues with social participation. And we've looked at how masking and adult issues can be very difficult for autistic adults. So let's look at what do we do about that? I've suggested to you to add some assessment tools if you don't already use those to your battery, but then what? So let's look at a few intervention examples and resources. So I came across this, the Autism CRC. This comes from Australia. It's the Cooperative Research Center for Living with Autism. And this is an intervention report. It's a huge report. It's a synthesis of a lot of research evidence. It's really new. It's in the last couple years, and it's free for you to download. If you click on the link, and I did, you download the report, and it goes in detail into different interventions at different ages. And so it also shows you, it's arranged according to models. And so it discusses the medical models of intervention. And then and those, autism is considered a disability. And the focus of intervention is primarily on the child and some impairment. It talks about a social model of interventions. And with those, they're usually geared around changes to the environment. They also discuss the biopsychosocial model of interventions. And this is something that the World Health Organization has endorsed. That is a combination of the medical and the social. And it talks about interventions that interact with the environment, the child and the environment that they live in, or the adult and the environment that they find themselves. And interventions that focus on those have the greatest participation. Then there's a neurodiversity model. And that one focuses on each individual's unique skills, and it more focuses on inclusion and participation. And so these are the models that are presented in this research paper and this book, and are also a way for you to view other interventions through these lenses. And you can think about, there's probably not any one, you're probably using a lot of different ones. Sometimes from the medical model, you might be stopping a behavior. Sometimes with the social model, you might be modifying the environment. And so when you go through interventions, you should be thinking about these different models and your perspective on which ones are ones that you agree with or disagree with. I'll show you a couple examples, and then we'll go to the Q&A. And this is the medical model, and this is what I just described. So there's one intervention curriculum. It's called Unstuck and On Target. You may have heard of it. This link will take you, when you do it on your own research, it will take you to this curriculum. This is one that's a school-based intervention. It's evidence-based, it's a curriculum. It provides lessons that boost flexibility and coping with frustration. It's, again, school-based, but the same group also has Unstuck and On Target for parents. So this is an interactive e-learning course for parents, and it goes along with the book Solving Executive Function Challenges, but it's specifically designed to support executive functioning and behavior regulation in children with autism. One thing I think is of interest, I don't know if you have seen this before, but what we haven't talked about today, it's not necessarily a mental health issue, but it is an issue in autism, is elopement. Very large numbers of elopement. And so the National Autism Association has created this tool that you're able to get to deal with elopement because, well, I mentioned our Johnny as a runaway. This would have been something great for me to have on hand in the group home when he came to us. There are so many programs, and that book that I mentioned from Australia lists for you very, very specific interventions according to each model. This happens to just be a group that I'm familiar with because as an assessment consultant, I worked a lot in the state of Kentucky for WPS. And the Kentucky Autism Training Center has a great number of resources. And I'm sure every state and most universities have similar. I was just familiar with this one, and I was most impressed with the fact that they put on courses for first responders, how to deal with autistic children and adults. And I think that's something that we don't often think about. So their interventions are very well received. This is again from the National Autistic Society. And then when you click these links, you get these guides. I will let you do that on your own. Accommodating employees. We didn't have too many people that work in vocational settings, but in the concept of working with adults, there are things to consider. And when I used to do assessments for vocational rehabilitation, this was important. What are some of the limits that employees are experiencing when they're autistic and on a job site? And when you get your copy, you can probably blow this slide up a bit, but this group, the Job Accommodation Network, is a really great resource again for interventions for adults. So you can see they have by work function. And so I just blew up the one on communication. Does someone need assistance with communication? Do they know do they need a service animal? Do they know how to do verbal responses? One of the things that I used to hear a lot of, someone might not know how to deal with difficulties with a coworker. How do you approach your boss? How do you discuss a coworker? How do you resolve a conflict? So this intervention resource for you is very good in that regard. Or by limitations. So a lot of interventions listed for attentiveness, managing time, memory loss, etc. So the National Autistic Society, the links that I showed you earlier, when you open those up, there's something we mentioned, autistic fatigue and masking. So one thing that most of these resources mention is something called energy accounting. And if you hadn't heard that term before, I just wanted to show you. It's creating a system with your client to set up manageable limits on your time. And it just goes on. I just showed you a few slides that goes on to describe what that might look like. Time without having to mask, reducing expectations. And then the next several slides speak to the Centers for Disease Control. I'm not going to go over each one of those. You can read them. There are interventions listed under each of these areas. So whereas before I told you the Australian book arranged by models, the medical model, social model, biopsychosocial, the CDC lists their models this way. So behavioral, developmental, educational, and so forth. So just quickly clicking behavioral approaches, most of you are most familiar already with ABA, discrete trial learning, and pivotal response training. And again, you will have these slides, and I'm not going to go through each of those. These are probably very familiar. Developmental approaches are those kinds of interventions that we typically apply early. And these are the ones that have shown in the research, if you can get to the children earliest with things developmentally and speech language, occupational therapy, etc., that you see great gains. Social approaches, social stories, social skills. And again, some of these also, CBT, I know we had some questions about CBT. That does take a certain level, obviously, of language ability. So I will turn it over now back to my colleague, Stephanie.
Hi, I am Stephanie Roberts, Business Development Manager of WPS. I just want to wrap up Anne's presentation so we can get right to her Q&A. So if you are interested in any of the assessments that Anne referred to today, you can get 10% off of these assessments by using the discount code. Let's go to the next slide. Also, if you have continued questions after today's sessions, you can also send an email to consult@wpspublished.com. If we don't get to your questions in the Q&A, this would be a good resource for you to access because we can help you with those questions and give you additional resources. Okay, and for all other inquiries, including customer service, quote request, technical supports, you can go to our contact us page at wpspublished.com/contact us. And we also put our WPS resources on here. A lot of people asked about the videos. Where do I get the videos? They asked questions about telepractice. We have a YouTube channel. There's so much information out here from a variety of authors. And we also have a link to our WPS online evaluation system where we have a lot of our assessments and the ability to use in telepractice. Mm-hmm. All right, so we're going to take the PowerPoint down now, and we are going to go ahead and jump to the Q&A. There are some questions that people submitted ahead of time. We're going to try to give some time to those questions and then get to the questions that were also asked during the presentation. Just real quick, and you also, oh, she is putting up the flyer right now for Haley Moss. Mm-hmm. And that is, it looks like it's a bit.ly link. So it's bit.ly/Moss Autism Action. But we can put that in the chat. I believe Laura was going to put that in the chat. So if you can bring all of that down and just bring us back to the screen, I'll get to the Q&A. Thank you so much, Dr. Rogers, for your presentation today. I want to get to, do you have any additional insight on preschool assessment?
Sure. And thank you for that question. So I think that the American Academy of Pediatrics has suggested to physicians that in addition to frequent well baby visits, that autism specifically is assessed at certain ages. And so clear back to well baby visits and working with parents, then autism should be being considered. So in terms of assessment, in addition to the SRS-2, which goes down to 30 months, and the MIGDAS, which is able to be done with youngsters, then there's also, if you look at the federal law in the US, the 5 areas that are required under IDEA: physical, communication, cognitive, etc. Then we also have the developmental profile is an excellent source for that, as well as the developmental profile. The adaptive behavior measures would go along with a comprehensive assessment, and certainly tools like the ADOS and the various modules of the ADOS.
Great. All right. So this next question that we have, it's going to be a little tough to unpack. Oh, let me just very quickly go back to also with the preschool, the DP4. I know is something also that people use with preschool. But let me get to the next question. It's going to take a little bit of time to unpack. So what are the various assessment tools when you want to work with adults? You know, a lot of questions came in about adults, and they're talking about, is play appropriate at certain ages? Obviously, that's a developmental question, and where the person's functioning. But can you tell us a little bit more about adults? I think that would be really helpful.
Right. And again, I think we could have spent another 90 minutes just on comprehensive assessments, but in terms of adults, you can use, and I think play, I'm glad you brought that up. So when you look at the adaptive behavior assessment system, the ABAS, it does have one scale on there called leisure. And since the ABAS goes from birth to age 89, then there are relevant questions in the leisure concept that you can look at. So adult play is also speaking to the restrictive range of interest and repetitive behaviors. And so I think you can assess and get an interest, and certainly the MIGDAS, because you come from a person's preferred interests and range of topics, and the adult assessment looks differently, the questions and the way you approach it on the MIGDAS, than maybe a nonverbal child. And so you still can get at those with the MIGDAS. You can get at those when you look at adaptive behavior, if you want to pull out certain aspects. And then as well, of course, the gold standard, the ADOS, you can use module 4 of the ADOS for an adult assessment. There are a number of tools. If you're looking for a diagnosis, or if you're looking to supplement your evaluation and looking for ways to create interventions that are most useful.
Great. Yeah, I mean, I know a lot of people have varying questions when it comes to assessing autism. We get questions all the time. So if we don't answer your question again, send an email to consult@wpspublish.com. Okay, so when you're looking at, let's see, differential diagnosis at the high school level, I know who may be seeking a diagnosis of autism. I mean, there's a lot of different approaches. I think you hit on this a little bit ago. Do you have anything else to offer at the high school level?
I would encourage for folks to remember what we said today. Is it missed or miss? And also the evolution of behavior and how that might present. The concepts of masking, the concepts of depression and anxiety. It's hard sometimes to tease out anxiety from social withdrawal. And so I think in terms of assessment, It might not be, I hear a lot of times, well, they can't be autistic because they're an adult, or they can't be autistic because they're in high school. Not so true. And that's why I presented so many slides in that regard. I think that a comprehensive approach for someone in high school should definitely include the MIGDAS, because that person gets to share their life experience. That's the point of the MIGDAS, and from their preferred interest, and look at differences in their brain style.
Right. I do like that assessment from Dr. Montero. I know that she takes great care in using that sensory approach. And I really love that she comes at it from a really different perspective than most assessments, because she's looking at the person's strengths too, and giving that picture. So that's wonderful. And you would use the ADOS too for module 4 for adults. Sure. Somebody asked that question who've never been diagnosed.
Right.
Okay.
And keeping in mind too, there's a lot of pressure sometimes in the field for the ADOS. And we all know that insurance companies most often require the ADOS, and ABA clinics, I hear all the time from ABA therapists that they have to give the ADOS. Have to, I don't think is the best way to put it, but I understand that there's an issue. There's a state that that I used to visit as an assessment consultant, and I heard from them a lot that they were being required by insurance to give the ADOS every 6 months as a measure of progress in the ABA clinic. Well, that's not what the ADOS is designed to do. It's not a progress monitoring tool. If you're autistic and you've been given that diagnosis, you are autistic. And just giving the ADOS again is only going to confirm that. It isn't going to show growth. And so with some of our other assessments at WPS, you're able to show trajectory over time. And particularly getting back to the SRS too, those treatment subscales can show change over time from intervention.
Okay. We are out of time, but I do want to ask you one last thing. Why did you pick the National Autism Society as your main focus reference point? Someone asked that.
I had a number of their slides when I was looking at adult. When I was looking for adult issues and adult intervention tips, I felt like that was very comprehensive, that source. I also had many slides from the CDC. I just, kind of moved through those quickly at the end.
Absolutely. They just wanted to know why you chose that as the model. So
I tried to, although I used the DSM, and I tended to cite a lot of US research, I wanted to also include things from other countries. So that's one of the reasons that I chose the UK, and one of the reasons that I chose the fantastic resource from Australia.
Yeah, and I know someone commented about the ICD-10 as well.
Yes,
obviously,
yes.
You always take that into account as well. You just wanted to bring up the DSM-5 and highlight it more because they have had that recent change. And so that's important to point out as well.
Right.
All right. And again, we want to make sure that if you have questions still and you want some information, we have experts in assessment, our assessment consultants. We also have a research and development department. We will be happy to address any questions, concerns, thoughts, give you resources, etc. Please email us at consult@wpspublish.com to get more information. This has been a great presentation. Thank you very much, Dr. Rogers. We appreciate your expertise and appreciate everyone attending the webinar. Thank you so much for attending, and we'll see you next time.
Visit WPS today to start unlocking potential.